All right, I'm going to go ahead and start the webinar and go live.
Hello, everybody. Good morning in the Pacific Northwest. Good afternoon in Europe. Good night in Asia. Welcome to another series of cerebrovascular questions and answers. My name is Matias Costa. I'm one of the cerebrovascular fellows at Swedish Neuroscience Institute. I want to thank Seattle Science Foundation and Swedish Neuroscience Institute for providing us the opportunity to screen these talks. This morning, I'm here with Alexis, which I want to thank, and my colleague, Dr. Cliff Pierre, one of the cerebrovascular fellows, who just came. Today we have the pleasure to have Dr. Tiago Baptista from Portugal. He's an interventional neuroradiologist from Lisboa. He did his residency at the Hospital de São José, Lisbon, which is the busiest interventional neuroradiology center in Portugal. During residency, he also completed a master's in endovascular neurosurgery in interventional radiology from the University of Oxford in the UK. And a few years later, he came back to Oxford to work as a consultant in interventional neuroradiology for a few years. He's now working at the Hospital CUF in Lisbon. And it's interesting, it's nice to remark that during COVID, he organized a series of webinars of INR that were attended by hundreds of colleagues worldwide, and it's called NeuroTalks. We will leave the link of those talks after this session at the bottom. So welcome, Dr. Tiago Baptista. You can share your screen.
Well, thank you, Dr. Matias Costa. Thank you for your kind introduction and for the invitation to participate in these webinars. It's a pleasure to me, and I hope it's useful. I'm going to try to share my screen now. Okay, I hope you are seeing it well. Yes? Okay. It's okay. Good. Okay, so good morning, everyone. Good afternoon, people here in Europe, and well, good night for those in Asia. It's a pleasure to me to be here and talk for the next well, 30 minutes or so about external carotid artery dangerous anastomosis, key anatomy and clinical cases. I'm going to go through these topics in the next half an hour. So it's impossible to talk. Oh, okay, so yeah, it's okay. If you want to understand the dangerous anastomosis between the internal and the external carotid artery, we need to understand the embryology of the arterial supply of the head. We need to understand and know the normal added anatomy of the external and internal carotid arteries. And also, doing that, we will be able to understand the main routes for dangerous anastomosis between these two systems, the external carotid artery and the internal carotid artery. And why is this important? Because we know that some of our procedures are actually based on embolization of the external carotid artery. So if we don't understand exactly the dangerous, how dangerous are these procedures, we might end up with very difficult situations. So understanding the anastomosis, the potential routes between the external carotid artery and internal carotid artery is of paramount importance for the safety of our procedures. Throughout this presentation, I will present some illustrative cases. So let's start with embryology. Let's go back to our medical school times. We all know that at the precaudal stage of the development of the embryo, by the day 24, we'll have the closure of the neural arch. And by that time, a set of primitive cells will start developing in channels, and these channels will develop in these paired longitudinal systems on the embryo. So we have this longitudinal neural system and then the aorta. And the aorta has also the dorsal aorta and the ventral aorta. What we know at this time is that the longitudinal neural system will become the posterior cerebral circulation, and the aorta will become the anterior cerebral circulation. So from these pair of channels that are forming by that stage, we'll have the adult pattern of the vascularization of the head. Regarding the head, that is our focus on this talk, we know that the development of the 5 secondary vesicles of the brain will need, or will be also at the same time of the development of the pharyngeal arches, and the pharyngeal arches are followed by the development of the vessels that actually will make the connection between the dorsal aorta and the ventral aorta. And of course, the ventral aorta is coming from the primitive heart. So these connections are very important to understand the adult pattern of the cerebral circulation. So if we go to the embryonic stage, that will be something like at this stage, we have the 6 pharyngeal arches followed by the 6 aortic arches. But we know that at the adult stage, that's not the case. We will have the common carotid artery and then the internal carotid artery and external carotid artery, both sides. So what the challenge here is to understand how we will come from this paired system connected by arches to this complex adult pattern that we know right now. Okay, so if we put it simple, we can say that there is a longitudinal neural system, the dorsal aorta and the ventral aorta. And as I said, there are connections between the dorsal aorta and the ventral aorta that are the aortic arches. The first 3 are those that are important for the cerebral vasculature, and they will change over time during the embryogenesis. So we'll have the adult part. How is that going to happen? So in the beginning, the proximal aspect of the dorsal aorta will involute. So that bit of vessel will disappear. So the remaining dorsal aorta that will become the internal carotid artery will be supplied by the connection to the ventral aorta through the 3rd arch. So the dorsal aorta, the proximal bit will disappear, and the 3rd arch and the distal aspect of the dorsal aorta will become the internal carotid artery. The proximal bit of the ventral aorta will become the common carotid artery. So we start understanding how the future internal carotid artery will appear. And then it will get close to this adult pattern that I've shown just before. After that, there are changes to the other arches. And the ventral aspect of the 1st and 2nd arches will also disappear. And the dorsal aspect of the 1st arch will also regress in order to obtain the adult pattern of the normal anatomy. Also, between the dorsal aorta and the longitudinal nervous system will appear a posterior division from the dorsal aorta that will become the posterior communicating artery. The anterior division of the dorsal aorta will become the anterior cerebral artery. And so at this time, we have the primitive internal carotid artery almost at this final morphology. And at the same time, the external carotid artery starts to develop and will become the external carotid artery through the ventral pharyngeal artery. The stapedial artery is this connection between the first and the second arch that will remain at some point and will disappear. And that's a very important artery that we will be back later on during this presentation. That is understanding this is understanding many of the anastomosis that are actually dangerous. And so you have the hyoid trunk and stapedial artery, and this connection between the second arch and the primitive external carotid artery. So what's going to happen next? This first arch is actually going to be the middle meningeal artery. The second arch will be the internal maxillary artery. But we know that these two branches are actually branches of the external carotid artery. So what's going to happen is that this hyoid trunk will regress, and there's an annexation of the ventral aspect of the first and second arches to the ventral pharyngeal artery that will be the external carotid artery. So this is kind of more the normal anatomy that we are used to. By this time, also, it's important to understand that because the embryo is growing, there are connections between the posterior circulation and the anterior circulation that will disappear, but at this time they are important and they can actually be in the adult stage. I'm talking about the primitive trigeminal artery, the aortic artery, and the hypoglossal artery that are actually following the nerves of the same name that will disappear during the embryogenesis. We also know that the primitive trigeminal artery is the most common persistence in the adult, and we can sometimes identify it during our angiograms. At the distal aspect of the primitive internal carotid artery, it is also important to name three other vessels: the primitive ophthalmic artery, the dorsal ophthalmic artery, and the primitive maxillary artery. Actually, these arteries will also have a very important role in the connections between the internal and the external carotid arteries. So here, the annexation of the middle meningeal artery and the internal maxillary artery by the primitive external carotid artery. By the time of the development of the 5 vesicles of the brain, there is all, as I said before, this need of connections between the posterior and anterior circulation, and the connection that is always very frequently present is the posterior communicating artery. It can be more important or less important, but it takes part of the circle of Willis. And then at the end of this carotid artery, the anterior and middle cerebral arteries. So let's just focus on these 2 regions so we can understand the most important steps of development of the embryo and understand the connection that might remain and understand how dangerous that they can be at some point. So let's talk about stapedial artery. So we know that this stapedial artery, as I said, is the remnant that connects the first and second arches and the hyoid trunk. And it has basically two branches, the superior ramus and the inferior ramus. The superior ramus also has a dual branch and a branch that goes into the orbit. This branch supplies dura and non-neuroorbital structures. The inferior branch goes outside of the brain, of the cranium, and supplies tissues in the infratemporal region. And it will anastomose with branches from the external carotid artery. The regression, as I said, it regresses. The regression of the stapedial artery will give origin to the stapedial remnant that is actually the carotid or tympanic trunk. You might remember that the carotid tympanic trunk goes into the region of the middle ear, has important connections with other branches that go and supply the middle ear. And middle ear is actually a kind of an interface, a place where many branches from different vessels go to, and potential routes of anastomosis can actually appear there. I'm going into that in details later on. The exocranial segment of the stapedial artery will actually give origin to the middle meningeal artery. The ophthalmic artery. The ophthalmic artery has this interesting way of developing. So, as I said, remember there is a ventral ophthalmic artery and the dorsal ophthalmic artery in the beginning. And the ventral ophthalmic artery actually comes from the anterior division of the dorsal aorta. And how is it going to the final position? Because the final position is not the anterior cerebral artery. Actually, the final position is the intracranial internal carotid artery at this point. So what we see is that this branch goes down into the final destination, and from here it goes into the orbit. The dorsal ophthalmic artery also involutes and will reduce in size and will give origin to the infralateral trunk. But by this time, it will only be the deep recurrent ophthalmic artery of the infralateral trunk. But actually, is an important route of anastomosis that you can imagine between the orbit and the internal carotid artery. If there is any kind of situation in these other vessels of the orbit, there might be the reverse of the flow that will come from the orbit into the internal carotid artery. And that might be dangerous if we are, for instance, embolizing some epistaxis, for instance. The variants of the ophthalmic artery are actually several, and I'm going to talk about the most important ones. One of the positions of one of the variants is actually the double ophthalmic artery, where the ventral ophthalmic artery and dorsal ophthalmic artery will remain, and you have two ophthalmic arteries actually going into the orbit. The other variant that is also not very common, but you can find it, is the ventral ophthalmic artery. So it remains the position that is the primitive position of the ventral ophthalmic artery, which is in the adult pattern, the anterior cerebral artery. The third variant is the persistence of the dorsal ophthalmic artery and the regression of the ventral ophthalmic artery. So you have the orbit coming only from the extracranial internal carotid artery. This is a real case of a patient that had origin of the internal carotid artery coming from the anterior cerebral artery. You can see the primitive position of the ventral ophthalmic artery going into the orbit, and you can note the choroidal blush very, very easily. The other variant that is probably the one that is more dangerous is dangerous in terms of not recognizing the origin of the ophthalmic artery, is the persistence of the supply of the orbit by actually the middle meningeal artery. Is it why it's called meningopophthalmic artery? And it comes from the connection from the inferior ramus of the stapedial artery through the persistence of the dorsal ophthalmic artery into the orbit. And I would like to thank, by this time, to thank you, Professor James Byrne from Oxford, for these beautiful draws that he has on his book. And the third area that I would like to explore slightly more is the cavernous sinus region and its connections to the external carotid artery and potential routes for dangerous anastomosis. We are going to talk about the dorsal ophthalmic artery coming from the inferior lateral trunk, the stapedial artery, the trigeminal artery, the primitive maxillary artery. They are all potential collateral routes to the cavernous internal carotid artery. So we can remember that the inferior lateral trunk has an anterior branch and a posterior branch. The anterior branch of the inferior lateral trunk is connected into the region of the orbit by the deep recurrent ophthalmic artery. Also, there is an anterolateral branch, so slightly lateral branch, that is connecting with internal maxillary artery through the artery of the foramen rotundum. And this is very important because with the occlusion of the internal carotid artery, this is a common connection between the cavernous or the cavernous region of the internal carotid artery and the external carotid artery, and can be very important in supplying the brain. The posterior branch of the infralateral trunk has connections with the external carotid artery through the foramen oval branch to the accessory meningeal artery, and also through dual branches to the middle meningeal artery and through the artery of the foramen lacerum into the carotid branch of the ascending pharyngeal artery. We go back to these again, so we make sure that we will not forget. Okay, so in another way, we have here the infralateral trunk and the anterior medial branch going into the region of the orbit, connecting to the recurrent meningeal branch of the ophthalmic artery. So this connection is actually in an hemodynamic balance that might favor whatever is needed. So if there is need for blood to the orbit, there will be blood coming from the internal carotid artery to the orbit. If there is need of blood in the internal carotid artery, there will be connection from the vessel that go into the orbit into the internal carotid artery. So is a second way of supplying whatever is important at some point. The artery of the foramen rotundum, as I said, goes also anteriorly, and anastomosis with the foramen rotundum branch of the internal maxillary artery. And then the foramen oval branch into the accessory meningeal artery branch of the internal maxillary artery as well, and the carotid branch of the ascending pharyngeal artery and the cavernous branch of the medial meningeal artery. So all these vessels coming from the external carotid artery are actually connected to the internal carotid artery through the infralateral trunk. So working near these vessels might be important to understand that at some point these vessels, these connections can open, and these can be also dangerous. Let me show you an example of how the artery of foramen rotundum can be important. This patient had an occlusion of the internal carotid artery here, and from the external carotid artery, actually from the distal branches of the internal maxillary artery, there is this artery of the foramen rotundum connecting to infralateral trunk and supplying the internal carotid artery. So the internal carotid artery is established by this connection with the external carotid artery. Let me go slightly through the anatomy of the internal and external carotid artery. So at the end, we can organize all this knowledge on embryology, connections, anatomy, and eventually understand all the dangerous anastomosis that we can find. So we all know the cervical vasculature, the internal, external carotid artery, vertebral arteries. So I'm not going to go into details in this part. I'd like to just to show you something that might be interesting, is why the external carotid artery is actually anterior to the internal carotid artery, because the external carotid artery comes from the ventral aorta, and the internal carotid artery comes from the dorsal aorta. And this is why we always find, or usually find, the internal carotid artery posterior to the external carotid artery. There are many classifications of segments of the internal carotid artery. Many. We are not going through all these. We need to choose one. And this is, for me, a quite rather simple way of classifying the internal carotid artery in terms of segments. And as a practical perspective, we know that the ophthalmic artery is usually almost 90% of the time located just distal to the distal dural ring. It means that it is intradural. So is why if we have an aneurysm that is actually after distal to the ophthalmic artery, is probably intradural aneurysm. So is something that we need probably to treat. The cervical segment of the internal carotid artery has no branches, so it's something that is not concerning us now. The Petrus branch has the carotid tympanic artery that goes into the middle ear, as I said before, the remnant of the stapedial artery. Here you can see, usually it's not visible, but sometimes when you have some kind of pathology, you can actually see it. The mandibulovidian trunk, usually you can't see either, is the remnant of the mandibular artery, but in some situations actually is possible to identify it. In the cavernous internal carotid artery, there is this meningoepiphyseal trunk, the infralateral trunk that I've been talking about, and also some other arteries. The meningoepiphyseal trunk basically has these major branches. The basal tentorial artery, the marginal tentorial artery, the lateral clival artery, and the posterior inferior hypophyseal artery. For the inferior lateral trunk, I've been talking about that. The recurrent branch of the inferior lateral trunk that goes into the orbit, the anteromedial branch, the artery of the foramen rotundum to the internal maxillary artery, and the foramen oval branch that goes into other branches of the external carotid artery. In the supraclinoid portion of the internal carotid artery, we need to talk about the ophthalmic artery, the superior hypophyseal artery, the posterior communicating artery, and the anterior choroidal artery. I'm going to focus basically on the ophthalmic artery, that is where connections between the internal and the external carotid artery are actually more frequent. We know that the ophthalmic artery comes from the internal carotid artery and has the central artery of the retina, the lacrimal artery on the lateral aspect, and the ethmoidal arteries on the medial aspect. So the anterior and posterior ethmoidal arteries on the medial aspect of the orbit. And you can see that it goes quite quite distal in the orbit and into the skin. So we know that there are other vessels that go into the skin in that region that might be a potential route of anastomosis with these vessels coming from the internal carotid artery. Another image showing exactly this distribution of the medial vessels, lateral vessels, and the central artery of the retina. From the exterior perspective, here is the nose, here is the zygomatic arcade, and here is the medial branches of the ophthalmic artery, the anterior and posterior ethmoidal arteries, and the lacrimal artery. And you can see that the purple branches are actually the branches that come from the external carotid artery, and the red branches are those that are coming from the internal carotid artery. And they are very close at the level of the skin. So potential routes can happen at these points. The posterior communicating artery, connection between the posterior circulation and anterior circulation, that will, as we remember from the beginning, be the posterior division of the dorsal aorta. And the anterior choroidal artery is also a branch, but for the purpose of this lecture is not that important. From external carotid artery. So the external carotid artery, as we know, has 8 branches, 3 anterior, 3 posterior, and 2 terminal branches. The anterior branches are the superior thyroid artery, the lingual artery, and the facial artery. The posterior branches are the ascending pharyngeal artery, the occipital artery, and the posterior auricular artery. And then the 2 terminal branches, the superficial temporal artery and the internal maxillary artery. Let's go to the superior thyroid artery because it's important, and sometimes we don't understand how important it can be. The superior thyroid artery has several branches that go into the structures here, like this infra-aortic artery, also branches that go into the gland. And we know that there is another branch that goes into the thyroid gland, that is the inferior thyroid artery. But the inferior thyroid artery doesn't come from the external carotid artery, but from the subclavian artery, from the thyrocervical artery. So there is a potential route from the external carotid artery into the vertebral artery of the other side. If we have, for instance, occlusion of the subclavian from the other side. So it's possible to embolize the contralateral vertebral artery through the external carotid artery. And that can be dangerous. Okay, let's go into another situation. The superior thyroid artery anastomosing to the other side, to the contralateral superior thyroid artery, and supplying the external carotid artery and the internal carotid artery through the occluded common carotid artery. So we have here through the thyroid arteries contribution to the contralateral intracranial artery, internal carotid artery. Lingual artery, just important to know that there are almost no anastomosis between the 2 halves of the tongue, so we need to be very careful if we want to embolize the lingual artery. The facial artery has anastomosis with other branches of the external carotid artery to the ascending palatine artery and the descending palatine artery that is actually a branch of the second portion of the internal maxillary artery. But that is not the connection, straight connection into the internal carotid artery. However, the facial branches of the facial artery are the inferior and superior labial branches, but also the lateral nasal artery. And the lateral nasal artery goes into the medial aspect of, let me show you here, the medial aspect of the orbit, and from the angular artery, the dorsal nasal artery can connect to the ophthalmic artery and supply the internal carotid artery. That's quite a very common anastomosis between the internal and external carotid artery. The facial artery, as I said, has these branches, but the most important one is this lateral nasal artery of the facial artery that goes into the angular artery next to the medial aspect of the orbit. The ascending pharyngeal artery has these branches to the viscerum, but also this neurovascular trunk and the inferior tympanic branch. So here's, as I said, the inferior, middle, and superior pharyngeal artery, and the posterior division that is actually the neuromeningeal trunk with the jugular division and the hypoglossal division. And also there is this inferior tympanic branch that goes into the middle ear. Again, here in a beautiful draw, the hypoglossal division, the jugular division, the posterior one, anastomosing with clival branches of the meningophysial trunk, and also with branches from the inferior lateral trunk and into the middle ear. So anastomosis between the ascending pharyngeal artery and the internal carotid artery. Here we have inferior tympanic artery, the carotid-tympanic artery, and the foramen lacrum branch of the ascending pharyngeal artery, and the recurrent lacrum branch from the inferior lateral trunk. The occipital artery is not very important here unless there is this stylomastoid artery coming from the occipital artery that goes into the middle ear and contributes to the facial arcade. Let's go into that. This is connections to the vertebral artery. That is not the case today, but the stylomastoid artery can also come from the posterior auricular artery, and this stylomastoid artery goes into the middle ear and to the facial arcade. Let me show you in a minute. Here, I just want to show you the superficial temporal artery that has these divisions, anterior and posterior divisions, and the anterior division goes very close into the region of the orbit. Here, a case that, let me show you. That's it. Yes. So it's the very pathological superficial temporal artery due to a fistula at the location of the craniotomy. So it's a very ectatic artery. So, and the last branch, and we finished anatomy here, the internal maxillary artery. The internal maxillary artery has a terminal branch of the external carotid artery, has ascending and descending branches. The first portion, the most important ones, is the anterior tympanic artery and the middle meningeal artery, and also the accessory meningeal artery. The middle meningeal artery, as you know, goes into the cranium through the foramen spinosum and enters the cranium at that point, and then has dual branches that go anterior and posterior. However, the middle meningeal artery, in the very proximal part, very proximal aspect of it, has these two very important branches. And I'd like to just remind you that if we are now doing embolization of subdural hematomas through the middle meningeal artery, we need to know that these two branches are in the proximal aspect of the middle meningeal artery, and they can be a very important route of anastomosis between the external and internal carotid artery, and compromise the vasculature of the facial arcade and of the middle ear. Let me show you here. So the facial nerve arcade, the temporal, the petrous branch of the middle meningeal artery here. So this is the middle meningeal artery as it enters into the skull, and then here in the proximal bit, the petrous branch that constitutes the facial arcade that also comes from the stylomastoid branch of the posterior auricular or the occipital artery. So this is the facial arcade that can be a potential danger when you are embolizing the middle meningeal artery. So as distal as you can go, is better to avoid this complication. Let me show you this picture to summarize the connections that we can have at the middle ear between the external and the internal carotid artery. So let's start with the middle meningeal artery, the petrous branch going into the facial arcade, anastomosing with the stylomastoid artery, branch of the posterior auricular artery or the occipital artery, the facial nerve arcade. Then we have the superior tympanic artery also coming from the middle meningeal artery. And then the anterior tympanic artery coming from the internal maxillary artery, the caroticotympanic artery coming from the internal carotid artery from the petrous segment, the inferior tympanic artery coming from the sinoinpharyngeal artery, and also the posterior tympanic artery coming from the stylomastoid artery. So all uniting here at the middle ear, and all possible routes for anastomosis between external and internal carotid artery. The accessory meningeal artery is important to anastomose from the internal maxillary artery and the internal carotid artery through the artery to the branch of the foramen ovale of the infralateral trunk. Again, the importance of these vessels to supply the internal carotid artery if it's occluded. The second portion is not important at this time, and the third portion is just important because sometimes when we embolize the sphenopalatine artery for epistaxis, for instance, there might be connections from the sphenopalatine artery to the anterior and ethmoidal branches that go into the nasal cavity. So, dangerous anastomosis. Are there dangerous anastomosis, or are there dangerous doctors that don't know dangerous anastomosis between the internal carotid artery and the external carotid artery? So, of course, even if we know, during the procedure, you might be embolizing something that you don't want just because you can't see. But as far as you at least know them, you might be more alert, more and recognize them if they actually open. So you know that anastomotic channels can open under the following circumstances. So they can, when you have increased intra-arterial pressure in the presence of high flow shunts, or collateral routes when occlusions of the major intracranial arteries occur. And they occur basically in these three points: at the orbital position, at the cavernous region, and the apocervical region. So I'm going to organize everything now, but before that, just let me show you the proximal, how close these all vessels are in the orbital region, coming from the superficial temporal artery, from the facial artery, from temporal branches of the internal maxillary artery, and also from the branches of the ophthalmic, of the internal carotid artery, the ophthalmic artery. So it's very important to recognize the choroidal blush and understand where is it coming from. So after everything that I've just said, I'm just going to summarize everything into two diagrams. And the colors are basically the origin of the vessels. So the proximal, the connection between the external carotid artery and the internal carotid artery through the ophthalmic artery is actually made by the middle meningeal artery and anterior meningeal branches into the lacrimal artery and the ophthalmic artery. Also, from the distal internal maxillary artery, anterior deep temporal artery, infraorbital artery can go into the lacrimal artery and join the ophthalmic artery. From distal internal maxillary artery, also the sphenopalatine artery through the anterior and posterior ethmoidal arteries going into the ophthalmic artery. And also the cutaneous collaterals coming from the superficial temporal artery and the facial artery. So all possible connections between external and internal through the ophthalmic. Here, and also, of course, the meningo-ophthalmic artery, when the ophthalmic artery is actually coming from or originating from the middle meningeal artery, as in this case. And the cavernous region, the ascending pharyngeal artery and the internal maxillary artery with their connections to the mandibular artery and carotid or tympanic artery, branches of the internal carotid artery, and also to the meningeal arteries of the clivus and of the tentorium into the meningeal hypophyseal trunk and the internal carotid artery. And from the internal maxillary artery, branches that also go into the infralateral trunk, as I said before, and all to the internal carotid artery. Here, a situation where the inferior tympanic artery is actually supplying the internal carotid artery through the connection to the ascending pharyngeal artery. So, and the last one, the connection between the artery of the foramen rotundum to the internal carotid artery through the infralateral trunk. We know that the artery of the foramen rotundum is a distal branch of the internal maxillary artery. So, in conclusion, I know that is a long talk, many arteries. I'm aware of that, but then you might be able to go back and, if you find it useful, have a second look at those diagrams. But in conclusion, the message of this talk is that deep knowledge of vascular anatomy is of paramount importance for diagnostic and interventional neuroradiology. Understanding the possible routes for anastomosis between vascular territories is necessary to reduce the risk of complications while performing endovascular procedures. I'd like to thank you for your attention, and I hope it's a useful talk, and I'm very happy to share other thoughts about this in the future. Thank you.
Thank you, Dr. Gutiérrez. It was a terrific lecture. I know it's a lot of information for one lecture. I mean, it's a broad topic. It was very well put together. So thank you very much. We have many questions here from people. I will try to ask you as many as possible if you have more time. The first one is if you can give a bit more information about the meningophthalmic artery.
Is it here?
In the chat.
In the chat. Oh, okay. Let me have a look.
Yeah, the first one is about the meningophthalmic variation. If you can just show a bit more about this.
Yeah, of course. Yeah, that's a very interesting one. I like that one very much. Oh. I think I have just stopped my presentation, haven't I?
Yeah, I have to share it.
Okay. So. Okay. I think you are already being able to see it.
Yeah.
Okay. So let me show you the meningophthalmic artery. Let's into the.
I think it's especially important to distinguish between the meningophthalmic and the recurrent meningeal artery of the ophthalmic, because sometimes it's a bit confusing to differentiate between that.
Yeah. So the meningophthalmic artery is actually an artery that supplies the orbit in the absence of other suppliers. So there is no ventral or dorsal ophthalmic arteries. There is no ophthalmic artery in the proper position. The irrigation of the orbit is coming from the external carotid artery through the remnants of the involution of the stapedial artery according to this schema. So this is the middle meningeal artery through the foramen spinosum and going into the orbit. So the orbit is completely supplied by the external carotid artery and no supply from the internal carotid artery. As far as we are embolizing the middle meningeal artery for any reason, we need to understand that if there is a choroidal blush that we might not be seeing at the beginning, it means that that might be this variant. Something different is the recurrent ophthalmic artery going posteriorly into the inferior lateral trunk that is actually the remnant of the dorsal ophthalmic artery. And this is a hemodynamic balance between what is needed at some point, or in the internal carotid artery, or in the ophthalmic artery, or in the orbit. Okay. There's here something. What is the safety point to perform embolization on the ophthalmic artery? Well, it's basically very, very risky, and is why fistula coming from the ophthalmic artery are usually treated surgically and not that much endovascularly, because it's very difficult to, in such a small structure, prevent the embolic agent to go into the ophthalmic artery and occlude the central artery of the retina. And the central artery of the retina is the terminal branch. So if it's occluded, probably there is no way of recovering from it. How many percent of anastomosis are the ophthalmic branch? Well, I don't know the number, but it's very, very rare. It's very rare. I don't know if there is more questions.
I have a few. Yeah, I have a few more. How do you choose your embolization material based on particles and particle size to be on the safe side for embolization?
Yes, we know that. We know that particles from reaching 200 to 500 are actually safer because they are supposed not to cross the capillary bed, and so they don't go into the structures, the neural structures. But having said that, of course, it's safer if you use larger particles, but it's always risky to occlude a vessel that goes into a structure like the facial nerve. There are colleagues in doing embolization of the subdural hematomas, for instance, from the very proximal aspect of the middle meningeal artery, and they are following up, they are monitoring the complications on the facial nerve. And as far as I know, they are having good results with no big problems. But as far as it's possible to avoid that, we should avoid.
Okay. Another one is, how often are dangerous anastomosis visualized, and how often are they visible on angiography? And if you don't see them, what is the likelihood that they are actually present?
Yeah. Okay. Yeah, that's a very interesting question, because actually we usually don't see them, and this is why they are dangerous. Actually, usually don't see it, and so we need to know where they are, so we can avoid them. So we can avoid them to open. That's the most important part. If you visualize it, of course, you have your work easier. But most of the times you don't see it. Or at some point they open during the procedure, during the embolization, and by the time it might be already too late. But of course, if you see them, you need to stop. But we need to do it before they open.
Okay, another question here is, if you had to choose 3 most important dangerous anastomosis to be aware of,
Which ones
Okay.
would you choose?
Well, I would choose, because for the frequency of treatments, all the anastomosis between the middle meningeal artery and the internal carotid artery. So these proximal branches of the middle meningeal artery are actually dangerous, and we need to avoid them. And the second one would be the ophthalmic artery arising from the middle meningeal artery or from unexpected location. And that is also something that we need to be aware of. And also anastomosis between the sphenopalatine artery and the ethmoidal branches, because we sometimes embolize epistaxis, and it's something that can be very, very safe if those anastomoses don't open. And if they happen to open, it can be a disaster. So those three, I would say, that are probably those that I recommend to be aware of.
Okay, there is one question here from Japan. He says that he experienced deafness after embolization of a meningioma. He doesn't specify which kind of meningioma. They have no idea which arterial anastomosis they caused the deafness. If you have any insights.
Yes, well, I can just talk in general. I don't know what happened, but a meningioma is a tumor that arises from the dura, and the dura is supplied by the medial meningeal artery. And as I said, the medial meningeal artery has these branches that go into the middle ear. So there is this possibility of embolization of branches going into the middle ear and the inner ear through the embolization of the middle meningeal artery. So it's something that might happen. Also, we also know that the inner ear is also supplied by the the anterior cerebral artery. So we would need to understand the case specifically.
Okay, and the last question is if you often see a dangerous anastomosis of the posterior circulation, like if you had any special cases.
Yes. Well, that might be another topic.
Yeah.
All these anastomosis coming from the branches that go into the posterior fossa, like the occipital branches from the occipital artery, or branches from the posterior auricular artery, and the anastomosis with branches from the vertebral arteries and dual branches from the vertebral arteries. And these kind of anastomosis of the pro-atlantal arcade and so on. So those are actually anastomosis that are important to know, but are less frequent to embolize. I'm just going to show you quickly. There's here. Yeah, here. So there are many dural branches in these posterior fossa regions. So we need to be aware of them. But that's something that is another topic.
Here we have they said that thank you very much for the response on the meningioma and deafness. The meningioma was paraclinoid. So actually I assume maybe they suppose that the occlusion was the anterior pharyngeal artery.
Okay, yeah, it's true. Through the inferior tympanic artery, that is actually a branch of the ascending pharyngeal artery.
Ascending pharyngeal, yeah.
Is why actually we need to we should avoid the embolization of the ascending pharyngeal artery.
Yeah,
it's just one of the reasons is that.
I mean, could also be one of the anterior tympanic from the MMA or IMAX.
Yes, exactly. Yeah.
Okay, so I think we are done with the questions. Thank you very much for this talk.
Well, thank you, Dr. Costa. Thank you. It was a pleasure, and I wish you very good a warm hug to everyone there, and I wish you a very good day of work. I know that we are starting now, so
Thank you.
thank you for the invitation.
Thank you very much.
Thank you very much.
Thanks. Bye-bye.